So good morning, everyone. My name is David Wessel, and I have the pleasure of introducing this morning's Grand Round speakers. As folks still come in from the back, we welcome you to take a seat here in the front row. And as you do that, we'd like to ask you, out of respect for the speaker, to turn your phones to vibrate as well as your pagers. Dr. Tessie October is our Grand Round speaker today. I have the pleasure of introducing her, but before I tell you a little bit about Tessie, I'd like to remind you that about 3 times a week in this hospital, something very serious happens. A child dies. And usually before that child dies, there's a conversation between the care provider and the parent, or sometimes the patient. And those are crucial conversations to have. I don't remember being taught how to have that conversation in medical school. And I don't know that historically we do a great job of incorporating that into our training programs, although we try. And so it's especially important that we have our faculty and clinicians who are interested in the research that surrounds how to structure that conversation, how to change it, and how to be receptive and sensitive to the particular family that you have in front of you, whose views may be different about death and dying compared with your own. So that's what Tessie's going to talk to us about. Tessie went to medical school at the University of Washington. She then was a pediatric resident right here at Children's National, and we're very proud of that. She left here and went on to be a fellow trained in critical care medicine at the Columbia Presbyterian Children's Hospital there, the Morgan Stanley Children's Hospital. She's now board certified in pediatrics and pediatric critical care, as well as the specialty of palliative and hospice medicine. She's been on the faculty now for 6 years, I think, or thereabouts, pretty close to that. And I was privileged to be one of many people that tried to recruit her back here from New York City to Children's National. And we've certainly benefited from her contribution as a clinician in the intensive care unit, but also in her research. She's NIH funded to look at these very matters that you see described there in her title. She got a K award not too long after she arrived here, and then she subsequently has a more advanced K award. And I always hesitate to say this, but she did something that I've been trying to do for a long, long time, and can't say that I've even got close. She applied for an NIH grant, and it got scored. You know how the scores have several scores that score from 10 being a perfect score, or 1 being a perfect score, and then 9 being the least perfect score. And you add all those up and multiply by 10. So if you get a 30, gee, that's pretty good. If you get a 25, it's great. If you get a 20, it's fabulous. And Tessie got a 10. And so she's embarrassed me in that way, but also has enabled us to be very proud of the work and the quality of the work that she does. And also, I see that as representative, as a validation of the importance of this work by the National Institutes of Health and other external organizations. So it's my pleasure to introduce Dr. Tessie October to talk to us about courageous conversations with parents and patients and their families.
Thank you, and thank you, Dr. Wessel, for that wonderful introduction. So I'm going to talk to you today about courageous conversations, and these are the conversations that we have with families around end-of-life care. So we'll start off by asking, by show of hands, who here has completed their own advanced directive or their living will? It's pretty good. I would say that's a little bit about 60%. That's actually very good. Do you know what the data show for the average American? What percentage of Americans do you think have filled out their advanced directive? Take a guess. 1%? 10? 20%. What about among physicians? What do you think that number is? 65% among physicians. And among the elderly, and for the studies, the elderly is actually considered 70, it's around 65% as well. So either we're as smart as our elders, or we know something that families don't know. So what I hope to talk to you today about is first decoding the alphabet soup of advanced care planning. There's a bunch of documents out there. We'll explore some barriers to having this conversation, hopefully talk about some strategies to mitigate those barriers, and then we'll talk about understanding the value of creating your own advanced directive and how that actually impacts the care you deliver. So, boilerplate, the definition of advanced care planning is it's the process of preparing for likely scenarios near the end of life. It usually includes a lot of information about your own personal values and preferences. It requires that you identify a healthcare proxy, and the goals really are to respect patient autonomy and improve end-of-life care. So what are all these terms? Most, the post, the post. Have you heard of any of these terms? It stands for medical order. So it's either medical order for life-sustaining therapy, or physician order for scope of treatment, or physician order for life-sustaining therapy, so on and so forth. Every state uses a different nomenclature, but they all mean relatively the same thing. It is an out-of-hospital order that conveys your preferences around treatment decisions at the end of life. And these documents are used for your EMS providers so that they know what you want when they come to your house for an illness. The only state that does not have a form is Rhode Island, and the District of Columbia actually also does not have one as well, which is shocking. Actually not shocking if you live here, but it's surprising nonetheless. What DC has is an armband where you basically said do not resuscitate or not, or if you don't have an armband. And as you can tell, the problem with that is it doesn't leave room for the nuances. It doesn't leave room for the gray area. If you just have an armband that says do not resuscitate, it doesn't tell the EMS providers more details about what you want in terms of do you want fluid resuscitation, do you want CPR, do you want meds? All those things can't really be put on an armband. When you look at in-hospital, the forms are different, but nonetheless, they're still order forms. And this is where we call DNRs or A&D. A&D is allow natural death or do not resuscitate. A&D is the terminology that we use here. And it is an in-hospital order form that conveys a patient's wishes regarding CPR and other life-sustaining therapy. So the live-in will, which is what I asked you about before, is the document that's really about future planning, whereas those other documents that I mentioned are really about what happens should something happen to you at that time. And it is a written document that, again, conveys your patient's wishes and preferences about end-of-life care when that person becomes incapacitated or unable to make decisions for themselves. It does require designation of a healthcare proxy, and it allows the patient to guide healthcare delivered for the future. So, you know, I'm talking about all these terms, and you may be asking, why is it important? Well, it's important because 83% of those with an advanced care planning document receive their desired wishes at the end of life. It's also important because 43% of dying patients do require some decision-making about treatment during their final days. And when you look at that 43%, 70% of those people who had to make decisions were actually incapacitated and unable to make those decisions. So somebody else had to make those decisions on your behalf. We also know that if you have a living will, you're more likely to receive comfort care along with life-sustaining therapies that you've designated that you want as compared to others. Most of the data that I just showed you were from adult studies. So we may ask, what about pediatrics? Well, families of children with life-limiting illnesses want to have these conversations. And when we ask them why, they say, mainly because we don't know how to have those conversations with our child. And so it's really important for someone to start the conversation. 82% of families want their child to participate in the decision. And work by Dr. Lyon, who was here, among adolescents with HIV has shown that they really want us to start this conversation earlier. So we know that it's important, but what are the consequences? Well, there are consequences that run the gamut. For the child, if we don't know their wishes, there are often delayed decisions. Not knowing the child's wishes can also be an important legacy building for the child. I will say that adolescents in particular are fascinating how they think about the end of life. A lot of times we think that they don't know that they're dying, but they do. They usually know they're dying. They know they're dying before we discuss it. And when you do give them a chance for legacy building, they have a lot to say. I remember a child in particular. She was an adolescent who had cystic fibrosis. She was a rock star. I mean, this girl went to every concert known to man. She had a music collection that was amazing, to the point that I thought that she might have 8 tracks as well as, like, everything else. And when we talked about legacy building, what she said was really important to her was that she had friends along the way who helped her while she was not well. And she remembered a concert in particular that she went to with a girlfriend who she had a cough and fit and she had to go out, and she came back, and that girlfriend sat down and told her play by play everything that happened. And she wrote her a letter and said, I remember that experience and this is what it did for me. That experience, she actually wrote letters to several of her friends, and she was able to give away posters and some of her record collection to friends in a very meaningful way. And I will say that not only did that help her, but it really helped her friends and her families cope with the idea that she was dying. When we look at the consequences for the family, they're also quite severe. There are a lot of psychological long-term consequences when families feel like they didn't participate in the decision-making process around their child's death, or if they felt that the death was a bad death, they usually have a harder time coping. And it manifests itself in prolonged grief, in depression, major depressive disorders, anxiety disorders. And it affects society in that when families have these psychological consequences, they often don't return to the workplace. And there are significant mental health costs that we as a society bear when families feel like they didn't really have the death that was optimal. So over the next few slides, I'm going to talk to you a little bit about some of the barriers to advanced care planning, because what I've told you is that it's important and that there are consequences when we don't do it, but we're still not doing it. So the question is, what are the barriers that's making it so difficult for us to actually have these conversations? And these are the barriers that have been described in the literature. The ones that we're going to focus on first are the communication ones, because that's at the heart of why we don't have these conversations. So when we look at communication, there are 2 major barriers. One is that physicians in general aren't necessarily comfortable having this conversation. We are skilled at many, many things, and I would say, especially for me being in the ICU, we spend a lot of time with the do one, see one, teach one, do one, or making sure that you're competent with putting in central lines before we allow you to go off and do that on your own. And yet, with these conversations around the end of life, we don't have that same sort of rigor in talking to families. And we will send our resident in and says, okay, go in and get that DNR. And these conversations they can have severe consequences. So I do think I want to take a step back and say that as providers, we may need to spend more time actually teaching this material. So when we ask families what they want, they said that communication is one of the most important elements of good quality care. In fact, there have been several studies that say that when parents are asked about the skill that they appreciate the most in their physician, they often say their communication skill is more important than their clinical skills. I probably would differ. I kind of want you to know what you're doing, but I do think that communication is important. And when we look at the elements of high-quality communication around end-of-life care, it really includes having a balance between understanding the values and preferences of a family and providing them with enough medical information that they can make informed decisions. So when we look at how this balance plays out in the adult literature, there's been quite a few studies that look at the imbalance of proportion of speech, meaning that physicians dominate the conversation, how much we speak, and what we speak about. We tend to speak more about medical information than psychosocial information and understanding families' values and preferences. And the adult studies have also shown that the more a family participates in the decision-making process around end-of-life care, the more satisfied they are with those interactions. So if I tell you that the balance of speech between a physician and a family is 71%, 29% in the adult literature, what do you think it is in pediatrics? What's your guess? Are we doing better, meaning we're allowing families to talk more, talk less, or about the same? About the same. So we designed a study to answer that question because it had not been done in pediatrics. And what we did is we audio taped family conferences around end-of-life decisions between physicians and family members. We use this system called the Rotor Interactive Analysis System, which is a robust, validated, reliable analytical tool that analyzes the speech down to the smallest increments. And it evaluates turn-taking to look at how much there's participation and dialogue versus more of monologue statements. It looks at both verbal and nonverbal communication, even though it's through an audio tape, by listening to the tonal quality of voice to detect empathy. And then it categorizes speech into these four major domains, looking at medical talk, psychosocial talk, partnership talk, and other talk. Other talk is chit-chat. How's the weather? How was parking? That kind of thing. And so our data are very similar to what has been described in the adult literature in that we dominate the conversation as providers. We speak about 78% of the time to families talking 22. And when we look at what we talk about, the majority of it is medical talk compared to psychosocial talk. And the psychosocial talk around end-of-life decision-making is really about understanding the parent's values and preferences around these decisions. We went a little bit further than what has been described in the adult literature by using something called the patient-centeredness score. And this is a comprehensive score that takes into account a lot of variables around the conversation. It is a ratio that has elements on the numerator are more of the psychosocial elements, so talking about wishes and dreams and hopes and fears and understanding their family's values and their lifestyle, whereas elements on the denominator are more of the medical elements such as prognosis or talking about medical treatment. And as you can imagine, the higher the score, the more psychosocial elements there are, the more satisfied parents tend to be with a conversation. So usually a score greater than 1 is considered a more patient-centered encounter. And for our study, we found that the mean patient-centeredness score was about 0.6. And it was associated with satisfaction, about a 10-point difference when the patient-centeredness score was greater than 0.75 as opposed to when it was less than 0.75. So what our early work showed us is that parents' values and preferences are infrequently discussed. Providers talk about medical talk and dominate the interaction, and parents aren't really actively engaged in the discussion. So we then wanted to figure out how can we improve parent participation and understanding their values and preferences around these decisions. So we went to Dr. Pam Hines' work because she's a leader in this field in understanding the parent perspective. And so her prior work included families of children with cancer who were making end-of-life decisions for their child and asking them questions about what is important to you at the end of life when you made these decisions, what values were important to you. It's a very easy survey for families to complete. It's 2 questions, takes them about 5 minutes. And what we did here is, if you can, to orient you to this slide, the x-axis is percentage of the theme that the family chose as the most important value to them, and the y-axis are the 12 themes that were listed. What we did was we actually asked families to rank these themes. So we would put them side by side to each other, 4 of them on a page, and ask them to rank them. And the reason we did that is that we wanted to know not just what guides your decisions, but what you say and what you do is very different. So when you have them side by side next to each other and you're thinking about religion, the role religion would play versus the role of making sure your child feels loved, over and over again, religion actually was a choice that families chose frequently as one of their guiding principles, but when they looked at them in comparison to the other choices, it fell out and it fell to the bottom. And for me, that was important because a lot of times we make assumptions, I would say I make assumptions that this family is highly religious and they base a lot of their decisions based on religion. But when you ask them about that value versus others, that actually doesn't guide their decision-making as much as we think that it does. And so the most common things that families reported were focusing on my child's health, putting my child before myself, making informed decisions, and making sure my child feels loved. And what this means is that when I'm making decisions about end-of-life care, as long as I know that my child feels loved, I know I'm making the right decision for my child. When we look at the importance of including the family in the discussion and understanding what's important to them, that's one aspect of it. The other aspect that we need to get at is why are we not having these conversations? And part of it is what has been reported in the literature is that physicians in general report anxiety about having these discussions. And they also report a lack of communication skills training. When we ask physicians why it's so hard to communicate around these issues, fear actually is the guiding principle. And it's a lot of it, especially if you have deep relationships with your families, you feel fear that you'll be blamed, fear that you may not know all the answers, or what if I'm wrong? Fear of unleashing a reaction and having to respond to that reaction in that family meeting when they start crying. It's always really hard to sort of deal with. And fear also of expressing your own emotions around a patient of yours who's dying. So we then asked in our research program, can we improve this communication? And so we've designed an intervention that has two parts to it. One part does take some work from Pam Hines, which basically says, we want to figure out if we can give providers what's important to families, ask families these individual 2 questions, take them 5 minutes, and they tell us what values guides them when they're making decisions. If we give that to providers before they have a family conference, along with provide some communication skills training to those providers, can we change the way we're having conversations? And so we designed our communication skills training program based on a program that was initially called OncoTalks. It was designed for adult oncology fellows. It has since been adapted for all kinds of providers, so for pediatric critical care providers, hospitalists, neonatologists, and so on and so forth. And people who have taken this course have said that they have increased comfort with having these discussions around the end of life. So our intervention really has the 2 components, providing the medical team with the individual family's values and preferences around decisions and providing a communication skills training program. And then it's a pre and post design. And the outcomes that we're looking at are really novel compared to what has been described thus far in the literature. Usually when we have communication skills training programs that have been described in the literature, the outcomes really just stop at the physician level, where it's, are you comfortable having conversations after you've had this course? Are you more confident in your ability to have these conversations with families? We decided to go further and look at some of the other outcomes because we know that those outcomes are also important. And for the parent, we're looking at, do you have any regret after the decision that you made based on the conversation you had with providers? How satisfied you are? And then we're also looking at some of the psychosocial outcomes, those long-term outcomes that we talked about before, such as their quality of life and their depression scores and so on and so forth. We're also looking at outcomes at the patient level. We know that if families talk about these discussions early in their disease process, that decisions are made a little bit more quickly. We're also going to look at length of stay and limitation of intervention orders and compare that with the pre and post design. So we looked at those two major barriers of communication. One of the other barriers that physicians frequently report is the decision-making capacity of the child. Well, I can't have this conversation because this child is not ready, or this family is not ready, or I don't think this child actually can contribute to this discussion. And I'm going to challenge you by saying there are a lot of data out there that suggests that children should be at the table when they're cognitively able to be at the table. This study from the New England Journal of Medicine was done among Swedish parents who had a child who died of cancer the previous year. And they contacted them, and they had an 80% response rate, which is a pretty good response rate around end-of-life decision-making. 147, or 32% of the families who responded had reported that they talked to their child about death and dying prior to their child's death, and none of those families regretted it. When you look at the ones who did not talk to their children, 258 parents didn't talk to their children about death and dying prior to their child's death. Of that 258, though, 100 of those were children less than the age of 8 who cognitively probably are not able to actually contribute to the discussion. But what was important from these data are that families who did not talk to their child about death and dying, they regretted it. They also looked at the psychological consequences of those families based on self-report, and families who did not talk to their child about death and dying prior to their child's death had more major depression and anxiety disorders. We've looked at this work also here, and what we found are that children sense they're dying, even if no one's talking about it. They know. They know because physiologically things are happening to their body, and they know things are not right. And they know that things feel different. They also want to protect their parents. When you ask children over and over again why they don't discuss it, they say, it'd be too hard to talk about it with my family. I don't want to distress my mom. I know that my dad is going through a financial burden, and I feel like I'm adding to that burden. I don't want to have this discussion with them. But I will tell you that Pam Hines' work has shown that children as young as 8 can actually handle this emotionally. And as I've sort of alluded to before, adolescents in particular, they want the opportunity to say goodbye, and they also want the opportunity to leave a legacy. So I would say that although we suspect that decision-making capacity of the child is a barrier, that's actually a perception and not reality. Children can and should be participating in these discussions. On the other hand, time is a barrier, right? How long does it take to have these conversations? It can take a lot of time, especially in the outpatient setting. What Dr. Lyon and her group has shown using the FACES tool, which is an advanced care planning tool for adolescents, is that it takes about 40 minutes to actually complete these documents. And we know that it's going to take multiple conversations. But I will challenge you that in the inpatient setting, you're actually saving yourself time. If you know what the family wants and you know what's important and what values they hold dear to their heart around these decisions, it changes the way you have conversations with them in a way that actually saves time. To address the time issue, the Centers for Medicare and Medicaid actually in October of this year has finally decided to start reimbursing physicians for having this conversation. So now our incentives are aligned with having these conversations. So there is some encouragement, and there's a groundswell that's saying that this is important. They established 2 new billing codes, both for the outpatient and the inpatient setting, and to reimburse physicians for talking about advanced care planning. And they've actually put money where their mouth is. I mean, $86 for an outpatient visit, for a half-an-hour visit, is actually a pretty decent reimbursement according to CMS. And you can actually get another $75 after that for an additional half an hour. In the inpatient setting, it's $80 for a hospital visit. So I will say that time, although is a barrier, we're moving in a direction to mitigate that barrier by making it less of an influence in terms of how we have these conversations. Prognostic uncertainty is another barrier that frequently is described by physicians. And the reason is that, children die in very different ways than adults do. This figure shows you the trajectory of illness of a lot of our chronic patients. So children with chronic illnesses, they tend to have, so this is functional status on the y-axis and time on the x-axis, and this goes up to 100%. Our children with chronic illnesses often have a functional status that's not quite 100%. They start out in a functional status of, let's say, 75%. And, you know, they're doing okay, and then they have an illness. And that illness might lead to, if they didn't have a tracheostomy before, they may now have one, or if they weren't on a ventilator before, they may now be on one, or they come into the hospital for a significant pneumonia or a sepsis episode. And what happens during that episode is that, you know, they stay in the hospital, they get pretty sick, but they recover. But where they recover to is not back to their functional status they were prior to the illness. And the trajectory of illness for children with chronic illnesses really looks like this, where there's a slow decline and multiple of what we call these scary dips. And what's hard for us as providers is to know whether or not that scary dip is an illness that they're going to recover from, or if that's a terminal event. And because we don't know that, it makes it hard for us to prognosticate what is going to happen with their child, right? I mean, I know many of you here have had families who said, oh my God, they told me that my child was going to die like 5 times and he hasn't died. So I don't believe a word you say. And that happens quite frequently, right? Because we prognosticate and we're actually not very good at it. I will say, though, that prognostic uncertainty often is a veil that we as providers hide behind to prevent us from having those discussions. Frequently, when we are uncertain, we just shy away from the discussion, which is what happens. But I will say that literature has been showing that discussing uncertainty can actually promote hope. And despite uncertainty, the values and preferences can still be discussed. In fact, when you are least certain, that actually allows the family to really listen to weighing the options and knowing the true cost of the decision that they're making. And so when we are uncertain, we often describe things in vague, overly optimistic language. We focus on the treatment instead of the outcomes, avoid the topics altogether, or we give families false hope. And when we ask families what they want, they say that those are some of the things that makes it really challenging for them to make decisions. We know that patients and families with unrealistic expectations request more aggressive, non-beneficial therapies. Right? So if we aren't telling them the true prognosis or giving them a sense of what is important to us and how the prognosis can lead to illness or death, we are giving them unrealistic expectations. Families who recognize the possibility of a poor outcome and understand the burden of treatment are more likely to choose less aggressive therapies. And so when we interview families about what's important to them, and this is some of the work that we've done, the families say overall they just want our recommendations. They trust that we as physicians have an expertise that we can provide to them. They trust that we know that we don't have the answers to everything, but you're giving your opinion based on the information that you have, and they want that. They want you to be honest. They want you to replace hope for cure or hope for a realistic outcome if you don't think cure is actually a realistic outcome. They really want you to hope for the best but plan for the worst. Now, I mean, I would say that hope is a guiding principle. It's something that I spend a lot of time talking to families about, mainly because what often happens with us is, as providers is we stop the conversation when the family says that they're hoping for the miracle. We're like, oh my God, these people are so unrealistic. How do they not know that their child is dying? It's unrealistic to think that. I mean, my viewpoint is that, well, why shouldn't they hope for the lottery, right? I mean, I play the lottery every once in a while. Why not hope for the miracle? Why not? If that's your only plan, though, that's a problem, right? If, as for my retirement plan, I'm like, I'm just going to do lottery, not going to do anything else, that's probably not a good plan. But if my plan is that I'm going to, play the lottery every once in a while, but I'm still going to actually have a retirement savings plan, that's probably more balanced. And so when families say that they hope for, an outcome that you think is unrealistic, allow them to have that. It's okay. But prepare them for hoping for what are more likely to be realistic outcomes. The last barrier I'm going to touch on here is the complex social environment. This is often something that providers say, it's so hard to have these conversations because there's so many people involved, and I don't really know who to talk to or how to talk to, so I just won't do it. And, we expect to have this triangular relationship where it's a physician, family, and patient, but that's actually not the reality that we face, right? We have these complex relationships where there are two parents, one lives in California, one lives here, they aren't talking to each other at all. The grandmother is the one who's actually the primary caretaker, but she has no decision-making rights for the child. There's the transplant actually happened at CHOP, and so they have a transplant physician who they're really in touch with and they value and trust their opinion, but we are the ones taking care of them. And what I would say to this is that when we have these complex relationships, the consequences are even more severe for not having these conversations because there are more people involved and there's more at stake. And so the answer to this is really to have a multidisciplinary approach and get all stakeholders present at the meeting. I mean, we have the ability to Skype and to, phone in and have providers and family members from all over the world participate in these discussions, and we should. Just because it's complex socially doesn't mean we shouldn't be having them. And as a team, pre-meetings help so that we all are on the same page and delivering one message. But then we also need to rely on all the wonderful support that we have here in the hospital and you also have in the outpatient setting, right? You have your social workers, your child life, you have your nurses, you have tons of people who also are stakeholders and have relationships with the families that are very different but also important to have in this conversation. So I hope that I've shown you that a lot of these barriers to having these conversations around end of life are perceptions and not necessarily reality. And the ones that are reality, there are things that we are actively trying to do to change that and strategies to improve the way we have these conversations. And there are tons of resources out there to help with having these conversations. So the Conversation Project it's a nonprofit, theconversationproject.org. It is based on the ideas that go into an advanced care planning document, but it's really designed for the layperson. It is a wonderful resource that I often tell families about that basically talks in terms that families can understand about some of this end-of-life planning. Prepare.org does the same thing. The Gift of Grace, which you may or may not have seen, is a document that, as a game that Ann Watson has been playing several times during this National Palliative Care Month. And it basically does the same sort of things that Prepare.org and the Conversation Project talk about, in that it really just puts it in layman's terms of some of the decisions that you have to make. I mean, it has funny sort of things in it, such as like, if you were not able to, who would you want to wash your butt? You know, it's stuff like that. And what that does is it helps you sort of frame who your healthcare proxy should be and who you want to visit you at the end of life. 5 Wishes is another document that of these 4 is the only one that actually can be used as an advanced care planning document across the country. It is valid in 42 states to be used as your advanced care planning document. And basically it's 5 wishes, and it talks about those same concepts, right? My wish for the person I want to make decisions for me is should I become incapacitated, the kind of medical treatment I want, how comfortable I want to be, how I want people to treat me, and what I want my loved ones to know. And this is an easy way for parents and families to answer these questions. And so I'll end by saying that this is the day before Thanksgiving, and I appreciate that all of you actually came. That was really nice of you. I expected to talk to myself, so that was good. There's a gift that you can give to your families on this Thanksgiving, and really it's the gift of knowing what your wishes are at the end of life is a gift that continues to give. So what we're handing out there in the back is advanced care planning documents for Maryland, DC, and Virginia. Take the one that is applicable to where you live. There's a lot of cross reciprocity in that if you have one from another state, most states will honor it. You need to check with your state to see if that actually is the case. And I put this out there mainly because I think it's important for us to have these conversations with families. We actually need to know what goes in these documents and what decisions we're asking families to make. And so with that, I will say thank you for your attention, and I need to thank all the wonderful hands who make my work possible, my mentorship team who are listed there, my colleagues in critical care medicine who have been my petri dish for my research, as well as the families and patients who volunteer their time. And I also would like to thank my funding sources. So with that, I'll take questions.
We have a few minutes for questions, and what was the microphone? Janice, I'll go work on the microphone.
That's okay. First, Tessie, let me congratulate you. That was absolutely superb. So great job. I wanted to find out more about what we're doing here in children. I think the points that Pam made last week and the ones you're making this week are really on target in terms of preparedness to have these conversations. But I'd like to hear about how we're training our residents, how we're training our fellows, how we're training our faculty members to have these conversations.
Yeah.
Again, congratulations.
Oh, thank you. Thank you. We are actually leading the effort in pediatrics in some of the work that's being done here. As Pam had mentioned last week, the Palliative Care SIG, which is our special interest group within CRI, has many funded researchers who are doing amazing work. Dr. Lyon is doing a lot of work on adolescence and advanced care planning. Pam Hines is really focusing on getting the patient's voice at the table. And my work is focused on providers. So some of the work that we're doing to improve the way we have these conversations is that we have developed our communication skills training program that will go live in the spring of this year. And it will first be offered to my wonderful petri dish of my critical care faculty. And I have to say that this is one of the things that that makes my work so possible is honestly what has been described in the literature thus far has been communication skills training program only at the resident and the fellow level. And my colleagues here have been so open and willing to challenge their own principles and talk about what their barriers are to having these conversations as well. And so our communication skills training program will focus on fellows, nurse practitioners, and attendings. What we're doing for residents is on a smaller scale, but we are incorporating that in our palliative care lecture series that we do with the residents. It's 4 lectures a year. We also have a palliative care journal club that any staff member is invited to join, and that's one where we talk about some of the more interesting data that sort of are emerging in the literature.
I'd be happy to hand this microphone off. I do want to acknowledge one other person in the audience who really has provided a powerful collaboration with Tessie, and that's Pam Hines. If any of you came to Grand Rounds, I'm sure many of you came to Grand Rounds last week. It was very powerful presentation, and this collaboration between nursing scientists and nursing research and what we would traditionally think as physician-based research is really very powerful in the institution, and we've seen it not only in terms of what it brings to our institution, what it brings to the field in terms of advancing our knowledge, but also in terms of the ability to secure federal funding. This collaboration between these two programs has been very successful. Tom?
Yeah, Tessie, that was a wonderful presentation, and these are the type of things that keep us busy in the Office of Ethics. And what I see is that you're getting me out of a job.
There's always a role.
Yeah.
Thank you.
Dr. October, skillfully, artfully, beautifully presented, and thank you so much. David, thank you for your words. You're one of the courageous few who has taken on this as a research program for your career. Would you speak to us about the challenges for you personally and professionally of having this be your research career?
Oh, that's a deep question. The biggest challenge has been in changing the way people think about this research, in that it used to be very much thought of as a soft science or not a science that isn't grounded in the rigors of academic research. And I will challenge that assumption by saying that we have qualitative and quantitative outcomes, that we in pediatrics, where our mortality rate is 3% in several studies that have been repeated, that can't be the outcome of interest that we look at anymore as deciding whether or not that can't be our guidepost, because what numbers of patients will you need to show a difference in mortality when our mortality rate is 3%? But what we know is that our functional outcomes are what is harboring society, and we know that families and patients have other outcomes that are of interest. And I think that is probably the biggest challenge, is sort of changing the framework so that we think of this as hard science, because it is. It is. It's academically rigorous. We spend a lot of time talking about the theory behind it. We have a very scientific approach, and we're looking at outcomes that affect society.
Dr. Steinhorn. Oh, Jen, Shooty.
Hi, Tessie.
How are you?
A wonderful talk. I'll sort of share everybody else's feelings on that. Two things I want to mention. One is a shout out, because I do feel like educationally we have taken some good steps in terms of helping our trainees in learning how to have these conversations. We within critical care have been lucky enough to have Tessie in our division, and we established a recurring conference for our fellows so that they are getting some practice. Tessie brings in some of our past families to talk to the fellows. She does role play with them so that they can sort of put themselves in the role of both the parent and the person leading the conversation. And whereas I think critical care fellows in general would rather hear about resuscitation and respiratory failure and sepsis, I think they have come to recognize the importance of sort of getting trained in that area as well, and I think that's been hugely successful. The second thing is a question. I find that paradoxically, perhaps, that family-centered rounds might actually hinder our ability to have some of these difficult conversations, because I certainly find with myself, if the family is there on rounds, that certainly isn't the place for these conversations. You're standing in a hallway, there's 5, 10 people on your team, but you almost subconsciously check a box that I've touched base with that family today, and I've had a conversation with them. And I wonder if either you have an opinion or there's any data out there on what sort of family-centered rounds, what the effect that has had on having those difficult conversations with families.
That's also a wonderful question. We have quite a lot of experience with that. That's part of the work that we studied with our initial work. We wanted to know where we're having conversations with families and what we're talking about. So we looked at conversations at the bedside, we looked at conversations during family-centered rounds, and also during the formal family conference. And what we found for the family-centered rounds part is that what families are asking is that we come back, is that they want to be present because as a parent, it fulfills their role of advocating for their child by being present at the bedside and participating in the discussion, even if they don't understand a lot of it. But what they want is that we come back, is that if we start that conversation, we respect their wishes in terms of their own where they want to have that conversation, how they want to have that conversation, who they want to have that conversation with. Doesn't happen on family-centered rounds where they have this huge team of people and it doesn't allow for personal conversation. So what they're asking is that we come back.
To follow up on Jen's question before I ask my own, what is your feeling about these large multidisciplinary conferences that we have where there are 2 parents and maybe a grandparent or 2, and then there are 15 consultants, residents, et cetera, sitting in the room that the family has to either bear their emotions in front of or protect their emotions from, kind of almost like ganging up on patients. What is your feeling? Because you said come back, and what we typically do is we have a multidisciplinary care conference with the family later in the day, and that's where we kind of, in a sense, either gang up on them to twist their arm to get them to do what we want them to do, because much of our conversation is manipulative rather than informative. And so speak to that a little bit, the best way to do this, coming back and touching base with them in a meaningful way, and then I'll ask my real question.
Okay. So I will say that one of my prior research assistants, Keandra Fisher, who is now in medical school, so I'm proud of her, this is one of the things that she wanted to look at because as she was doing our work, she found that some conferences have 15 people. And of the 15 people, 2 of them are families, and the rest is like this cadre of people. And so she wanted to look at the structure of a family conference and who participates. So she's doing a secondary analysis of our primary data to look exactly at that question, at parent satisfaction with the conversations, and does it inhibit parent contributing speech to that conversation? As to my recommendations for how to have these conversations, I do think that there are two things that have to be considered. One is that we have to remember that the family has to be at the center. So we ask who they want to be there, right? I mean, if they have an amazing relationship with the palliative care team, and their relationship is with you and not with necessarily the entire team, it may mean that the team fragments and only you come to that meeting. It's also important to have these pre-meetings and create a bit of a structure around it. So I will say that the average meeting is about 44 minutes. What the literature shows in terms of satisfaction, this is adult literature, is that 30 minutes is sort of the sweet spot. So if we're having a meeting with 40 people, it's hard to get that down to 30 minutes. And the reason they say that 30 minutes is sort of the sweet spot is that's around the time when people start checking out. It's information overload, especially if we spend a lot of time talking about medical information that's very complex. We use words like ECMO. We use words like ambulate. Even physician language that is non-medical is still complex because we're highly trained, really smart people. And so it often takes families some time to decode some of that language. So part of that is creating a structure so that you say, what agenda do you want to talk about, asking the family? Because if they're really interested in, they're focused on the fact that the child's big toe looks green and it hadn't looked green before, but you want to talk about end-of-life decision-making, there's no way that they're cognitively going to be able to hear you when you talk about end-of-life decision-making if you haven't addressed their toe. So I always ask, what agenda items do you bring to the table? And then I tell them what agenda items I am planning on discussing and make sure that we have room for all of those things to happen.
Thank you. So the implication of your work is that every clinician, every physician for sure, and probably every nurse or advanced practice nurse ought to be able to have these conversations at varying degrees of expertise based on their experience, et cetera. And that's well supported both in adult oncology and surgery and emergency room medicine, that you can train people to be more effective in having this conversation, to learn some key phrases that they can use for these conversations to kick things off. So the question for you is, so what role then does the palliative care team play aside from symptom management and those sorts of things in an ICU-based practice, or the health team that's already dealing with chronic medical complex patients with whom they've got a long-standing relationship? Can you speak to that, please?
Yes, absolutely. Some of the work that Debbie LaFond is doing also is to, Panda Cubs, is to have a ground sort of support of providers who can start the conversation. Where I think the palliative care team comes into play is that we're experts in this field of communication. We spend the entire year of our training talking with families and really honing these skills. So the palliative care team still brings an expertise to the table beyond symptom management that we can learn from. As a palliative care team member here, I enjoy going to meetings with multiple members of the team because I'm still learning. I still learn key phrases that they use that I think are really good. And when the palliative care team is present, it changes the conversation. So some of our work that I didn't present here, we looked at when the palliative care team is present, how does the conversation change? And what we found is that the conversation becomes more parent-centric, that the palliative care team spends more time talking about goals and preferences than talking about medical information, and they can direct the conversation. The palliative care team actually often initiates the discussion by asking questions on the parent's behalf. And lastly, we found that the palliative care team's presence allows other providers in the room to actually talk. So when we looked at some of our initial data, when we looked at the providers, 86% of the talk was provider talk. Of that, 77% of it was the physician, and the rest was the rest of the team. The palliative care team may say one thing that allows the social worker to give his or her input, and allows the bedside nurse to give his or her input, and so on and so forth. So there's definitely a role in the same way there's a role for the ethics team.
So, Tessie, thank you very much for the presentation. We really enjoyed it. You reminded us to listen to patients and parents, to listen and not dominate the conversation. And I think we need to do that better in all domains of our care of the patient and the family. So with that, I want to note that we have about 3 or 4 minutes before the clock strikes 9 o'clock, and if anyone in this room does not have their flu vaccine, you can go to the mini atrium now and get it. It's really an obligation that we all have to our patients. But back to Tessie. Thank you all very much.